The TAILORx study was a study which attempted in a prospective fashion to validate the prognostic and predictive aspects of the Oncotype test for patients with node-negative, estrogen receptor positive, HER2-negative breast cancer. And what was done was a stratification of patients based on their relapse score on the Oncotype into low, intermediate, and high-risk groups. The low-risk group had a relapse score of 10 or less, intermediate between 10 and 25, and high more than 25. So in the TAILORx trial, patients who were found to have low-risk disease were automatically assigned no chemotherapy. Patients who were in the high-risk group received chemotherapy in addition to their endocrine treatment, and patients in the intermediate risk group got endocrine treatment with a randomization to receive or not to receive chemotherapy. Now, the data which have come out today are the data from the patients who were in the low-risk group who got endocrine therapy as their sole systemic treatment. And the results are absolutely amazing. They have shown that the Oncotype in this group defined an ultra low risk of developing metastatic breast cancer. In fact, one would have to say that the Oncotype, if anything, slightly overestimated the risk. These are a group of patients defined by the Oncotype who have an extraordinarily good outcome. More than 99% of them are free from a relapse with metastatic breast cancer with 5 years of follow-up. So the key thing to say here is that clinicians and patients who are worried about not taking chemotherapy when they're in that low-risk group need to be ultimately reassured they don't need it. There is no evidence that chemotherapy will make any difference. All they're taking is toxicity, all they're taking is side effects. They're not getting any benefit. For patients with Oncotype defined, very low risk breast cancer, chemotherapy is just not in the equation anymore. We embraced the study very enthusiastically. 700 and something Irish patients joined the trial, including 170 in my own institution, St. Vincent's Hospital. I think we were either the biggest or the second biggest accruers for any single institution in the world. So working on the data that we've seen today, approximately 1/6 of those Irish patients, something over 100 people, 100 women, would have been in that very low risk group. And as a result, they didn't get chemotherapy. And we now know they were right not to get chemotherapy. They didn't need it. They've done incredibly well. Without the Oncotype, I believe at least 1/2 of those patients might have been considered for chemotherapy. So we've saved an awful lot of Irish women from the side effects of chemotherapy. We saved our state and its health service colossal expense from chemotherapy which would have been given, which was toxic and redundant to the outcome of the patients. So this has had a very big impact in Ireland. An awful lot of Irish women, I think, should be very, very happy with these data. We need to get the data from the intermediate group where the randomization is taking place. I suspect that will take a little while longer. But in general, and I'm editorializing here, in general, those who worry that perhaps the Oncotype is giving a false sense of security about people who maybe should take chemotherapy, these data would suggest that's not the case. If anything, the outcome for these patients is somewhat better than the Oncotype predicted for the very low risk group. So I think my personal belief is that we will see increasing reliance on the Oncotype as a critical determinant of the decision as to whether we will give people chemotherapy or not.